Good morning, everybody. It's that time. I wanted to make a quick introduction. I'm Evan Klass. I am the Senior Associate Dean of UNR School of Medicine, and I'm the Director of Project ECHO. This program is the first of a series, and it is being sponsored under a state grant, which was received from the federal government under the Cures Act, to enhance treatment for patients with opioid use disorder. ECHO in Nevada is one of 20 ECHOs around the United States that are participating in grants of this sort. And ECHO was selected as a tool for doing this because it has the capability of disseminating best practice information broadly and with great flexibility. So we're really thrilled to be engaged in this project, and we've put together in a really extraordinary hub team for you, and we're going to go around the room and everyone will introduce themselves to you. But the goal, the specific goal for this clinic is to do what we've struggled to do in the past, and that is to activate clinicians to actually engage in providing medication-assisted therapy. In Nevada, we have many providers who have become certified to prescribe, but we don't have a lot of providers who are actually doing it. And we think that that disconnect is an area of great opportunity. And we're hoping that through the use of this program, we can assist and support providers who have been hesitant to initiate this sort of care, or who are doing it but want to enhance their practices. We would love it for everyone who's engaged to be maximally active, to be seeing and treating as many patients as they safely can, and to ensure that they are safely doing this. So we think this is a great opportunity, and this is the first of what will be a twice per month series, and it alternates Wednesday mornings with our pain and addiction ECHO clinic. So every Wednesday morning at 8, unless there's a fifth Wednesday in a month, in which case we kind of get a little disoriented, but Wednesdays 1 through 4 will be alternating pain and addiction and MAT ECHO clinics. So without any further ado, I am going to turn this over to our hub team, and I think we'll go around the table from my left and everyone will introduce themselves, and then I would like everybody who's on with us to introduce themselves as well and let us know who you are, what you do, and what your involvement in this area is. Thanks.
Mark Broadhead. I'm an addiction psychiatrist currently with the VA Medical Center. I run the Suboxone buprenorphine clinic for addictions at the VA Medical Center, along with an inpatient psychiatric unit. And I do the bulk of the teaching in addictions for the residency program in psychiatry with the University of Nevada.
My name is Carol Hain. I'm a physician's assistant. My background primarily has been in pain management for about the last 13 years. We used Suboxone oftentimes in pain management to transfer people off of opioids and then off-label for the pain benefit from buprenorphine or Suboxone. And now I've been with the Northern Nevada Hopes for the last 4 months. I'm working with Dr. Alteson on the team for the medication-assisted treatment at Hopes.
All right. Good morning, everybody. My name is Danica Pierce, and I'm a licensed clinical social worker. I specialize in co-occurring disorders, so mental health diagnosis and substance use disorder. I am at Hopes, obviously. Most of our team is from Hopes, in the medication-assisted treatment program. And so I do individual therapy with many of the people who are in our program, and then also kind of help coordinate all of their treatment, making sure that they're getting the behavioral health piece in addition to the medications that they get from us.
Hello, everybody. My name is Pete Ledlow. I am the nurse case manager for the MAP program at Hopes. And before I came to Hopes, I worked as a psych nurse in an adolescent treatment center. And so I've had experience working with behavioral health, mental health, and substance abuse for a little while. Just over this last year have I been at Hopes and actually worked with adults, and specifically with opiate addiction. There was another nurse that was doing this before with our old practitioner, Dr. Denko. She's given me some good tips and training on how to take over the program. It's been a great learning experience, and I get to work a lot behind the scenes with the patients and try to keep them calm and coming to their appointments and together with the team. So I'm glad to be here. I'm looking forward to this.
Hi, I'm Jennifer Farfan. I'm a medical assistant at Northern Nevada Hopes. I've been working directly with the MAP program. I help Pete, Danica, and Carol, as well as Dr. Altonson, with our patients.
Hello, everybody. My name is Kresh Rogina. I'm a clinical pharmacist at Hopes. And our job, where everyone else has their components of behavioral and nursing and stuff, is to not only provide regular, pharmaceutical type guidance, but also when we have issues with billing, whether it be quantity supply, limitations, PAs, to facilitate all that as smoothly as possible so people can get their prescription.
Good morning, my name is Chris Marchand, director here at Project Echo. Pretty much I handle the day-to-day nuts and bolts of the operation, make sure that everything's good to go. All the planning stuff that goes into this stuff, and then the implementation things as well.
Hi everyone, my name is Anna Ramirez and I'm also a medical assistant assisting with this program.
Great. So let's go around. So we see something up in our left, which is, I can no longer read it.
Ryan Cavella.
Hi, good morning. My name's Ryan Cavella. I'm the Director of Adult Crisis Services at Health Choice Integrated Care in Flagstaff, Arizona. We are a managed care organization here working for Access, which is our state-run Medicaid agency. And we are similarly a recipient of a grant from the federal government for the state targeted response to the opioid epidemic. And I would say that we have a very similar interest to you in maximizing our prescriber pool here in Arizona. We have a very similar issue. Many people who are certified to prescribe who are not comfortable doing so.
Good morning, I'm Sunshine Kaufman and I'm the Adult Programs Coordinator at Health Choice Integrated Care in Flagstaff. And Ryan pretty much said it all.
Okay, Amani Altamimi, tell us who you are.
I'm a primary care doctor at Nevada Health Center in Carson City.
Great, welcome. Alton Waters?
Can you hear me?
Yes.
I'm an internal medicine doctor, been practicing in Nevada for 38 years. See a lot of chronic pain patients. Very interesting in what you all think.
Where in Nevada are you?
In Las Vegas.
Las Vegas, great. Welcome, good to have you. Dr. Van Gilder, introduce yourself to this new group.
Good morning, I'm Dr. Van Gilder. I work out in Lovelock. I'm a family doctor. I've been doing MAT for almost a year now. I have about 8 patients who I've seen total. Currently I only have 4 active. That might be coming down to 3 due to some issues maybe we'll discuss later.
Great,
Thanks.
Thank you. And Steve was here. Steve,
It's Dr. Sung, but it looks like he signed off. I'll follow up with him now.
okay. Alan?
Thank you. I'm Alan Fisk. I work out of the Elko office for OSI. I provide technical support if you need any assistance along the way of getting your technical things set up for the Echo or whatever video conferencing. Like, please give me a call.
Great, thank you. Okay, so again, this is our initial clinic. We have a presentation for this morning. Unless anybody out there has any issues that they want to bring forward, I think we probably ought to dive right in.
So what I got was, so it sounded like everyone actually is currently doing a little bit of MAT already. And I think they were talking about, Ryan was saying that they're looking to expand their pool of prescribers there. So so MAT is not necessarily new to everybody in this group. Is that the way that I understood it?
Mm-hmm.
Oh, okay, great. So I guess some of the slides, you know, you may already be well rehearsed in some of this. So we'll just have the opportunity to be able to, you know, discuss some difficulties that maybe you guys are having in your area, or successes, or, you know, I'm free to have anyone ask me questions as we go along. The slides are pretty simple. We weren't quite sure how much everyone was going to be, how experienced everyone was in this field. So looks like we'll be able to have some good conversations. Let's see, do I control this here?
Yeah, right.
Okay. So just jumping right into what is medication-assisted treatment. Including treatment programs, OTPs, provides a combination of behavioral health therapy with medications to treat substance use disorders, as defined by SAMHSA. Hopefully everyone is familiar with the SAMHSA website. That's usually where I get a lot of the information that I need regarding MAT, some of the latest studies or research that's being done. And what I usually pull from their website is a lot of opiate, you know, physician guidelines or pocket guides to setting up programs. They have a great website. So these are the medications that we typically will prescribe. Well, not all of them, but these are the most common that we see in MAT programs. I don't know if anyone else has tried to introduce some other medications in their own program. I know there are a few here that aren't listed. Some medications like LAM that aren't really practiced, or aren't very used very frequently in MAT programs now, or at least maybe not in this area. So buprenorphine, Suboxone, probably one of the ones that's most common in our area. Methadone, naltrexone are still very popular here. Those are mainly for the opiate addiction side. Naltrexone also, which has been used for alcohol, curbing alcohol cravings, which yesterday we had a discussion, a MAT training. We actually found out that we didn't know that naltrexone actually didn't help curb some of the cravings for opiate addiction. It's just more of an opiate blocker. And we were learning that most of the studies are showing that it actually works only for cravings, mostly for alcohol. And then we have Antabuse and Camprol. We haven't done a lot of those at our clinic. Maybe Antabuse a little bit. A lot of the primary care providers will prescribe some of that at Hopes, but we haven't really done a whole lot of it in the MAT program. Then Chantix, Wellbutrin, and we don't do a lot of nicotine replacement therapy, but we definitely do have a lot of our patients that are coming in that are looking to, really cease any kind of addiction that they have. Chantix has been very popular, and Wellbutrin as far as helping to overcome some of the tobacco or smoking addictions. And we've actually seen a lot of people that have responded well to that. That's that's generally one of the last things that go once they've gotten all their other addictions in place. Smoking is just kind of like one of those last little habits that is tough to let go of, that old lifestyle. So one other medication that's fairly important that we prescribe to every single patient that we have, and that's Narcan or naloxone. This was from last year. We had a conference. The health department was there, and they were giving us some statistics on how overdose has affected our areas here in Nevada, and really some alarming numbers. Nevada, I think, on most of the studies, I think they found that Nevada has some of the highest rates of overdose and some of the largest need as far as treatment goes for opioid addiction. I don't know the specifics in your state where you're at, but we're seeing, a slight decrease, over the last 5 years as far as total numbers of deaths, but even still, it's still very high. So that's how it's affecting our area. There's been a lot of push for Narcan, I think, as everyone's probably seen in, not only by the federal government, but, local governments and communities coming together, and pharmacies really making it accessible to pretty much anybody now. I think most pharmacies now are moving towards having an open prescription for anybody who wants to get it. We recommend it for even, we try to get it out to even the families of people who maybe have a family member who's addicted, and whether they see them a lot or not, we just have been encouraging having these in the homes and just there, because accidents do happen. Sometimes, it might be, maybe suicide related. But as you can see in this slide, most of the overdose deaths are accidental. And a lot of people find that very alarming. I think there were a lot of people that thought it was, maybe purpose-based. But accidents are alarming. And one of the trends that we actually saw was that there was a huge number in accidental overdose in the population between 45 and 65. So that's a growing number that we've been seeing. That's pretty alarming. And I don't know if that's, maybe just more people are moving towards prescription medications. I don't know if there's been more pain that's, being prescribed for people that are, that age group, or if there's just, a lack of education that's been for that age group and not understanding a lot of their medications and the combinations of those with maybe benzodiazepines. And so we're working to improve in that area for sure. Most of our patients in our MAP program are younger, usually between like 20 to 35, but we have a few patients that are in their 40s, actually even some I think in their 50s. These are the most common barriers that we've seen in most MAP programs. We've been able to overcome a lot of these already, just having a lot of support from our administration team and some local community leaders. I'm sure that many of you have already come across a lot of these barriers in your own area. Lack of available prescribers is one that I've already seen, and I think that's probably why we're all here, is trying to get more and more people being able to bridge the gap either between primary care facilities, maybe in rural areas, and trying to help some people that are getting into maybe treatment centers, maybe just bridging that gap, hopefully, from their clinic to maybe, inpatient or, some IOPs or wherever they need to go. So there's obviously a lack of support for existing prescribers. We have seen, a little bit of, a lack of appropriate level of care, and maybe, it's more of like the numbers. We don't have enough inpatient facilities, maybe detox facilities, for patients who are still, struggling to stay either on their Suboxone or their methadone. They're still using, and in an outpatient facility, that's made it a little more difficult for us to continue treatment with them. So if they're still struggling, we want to refer them to some of the local, the acute centers. And most of the time, those acute centers are full. And it's very difficult to get them in. So have an appropriate level of care and where to refer people if your office setting is not appropriate. That's been a big difficulty. Some regulatory policy, obviously we're making big changes in Nevada for that. Attitudes and misunderstanding. With our atmosphere here, I think we're seeing a lot of people growing more towards this model of MAT and OTPs. There's still a lot of stigma out there as far as trading, either their addiction or their dependency on pills as, just trading one addiction for another. And we've really had a lot of good trainings over the last year that we've seen that really disproves that myth. And understanding the science of addiction, I think, is really key in that. There's actually a judiciary training that's going on right now here in Reno, where they're educating the judges, many attorneys, prosecutors, DAs, and all the specialty courts more about the science of addiction and teaching them how to sentence and sanction people according to their diagnosis and their substance abuse issues, and looking at this more as a disease and not just people choosing to break the law. So we're seeing a lot of changes as far as in our local community on that. I work specifically for our MAT program. We have a contract with the Youth Offenders Court in our area, and that is a program where they've seen, ages 18 to 24, they're finding that, because they still, their brains still aren't fully developed, and putting them in jail constantly over and over again for opiate or any drug-related charges, they're finding that it doesn't do anything for that population. They are right back there engaging back in the same activity, whether they were in jail for a year or two or 1 month, regardless of what it was, they were still going back to that same thing. And so they were seeing this problem, and then they were finding that studies were showing that, cognitively they were not fully developed, and they weren't really getting this process of breaking the law. And they were more vulnerable, to, their population is more vulnerable to some of the things that addicts are faced with. And so the Youth Offenders Court is about bringing in that population, and instead of putting them in jail, we're putting them in treatment. And so I actually go and I sit with a couple of the local judges with the DA, and they have a defense lawyer that helps represent some of the clients, and they have some social workers, therapists, and specialty court officers. And we sit together before court and we talk about the clients and how they're doing. Some of them, may not be fully ready for change as far as the psychosocial aspect and making positive choices. And so the ones that are still struggling, we try to avoid just throwing them back in jail. We really look to, if they are making mistakes, maybe they might hold them in jail for a little bit until we can transfer them into an inpatient program or transitional living, something that's going to have more structure. And this has been a great program. And if they can finish it, their charges are dropped, they're wiped clean. And so that's given them, an extra motivation to do well in the program. And we take direct referrals from them, and we've seen a lot of great results from them, giving them a second chance. We love that program. So moving down, understanding medication dosing. We've seen, a lot of providers just not understanding how the dosing works. Understanding Suboxone, do you start them on a higher dose, on a lower dose? How do you transition them from maybe being an active user into somebody who is only taking Suboxone? Dosing, we've seen a lot of experts, arguing both ways, whether to start them on a high dose or gradually move them up in doses. I think there's still a lot of research that needs to be done knowing the individual patient that you have, I think is the most important thing in deciding doses. Training requirements to get going in MAT, that, you know, it takes a lot to get your staff trained, starting from your medical assistants to how you're going to be billing for, your visits. A lot of that, and understanding the addictions, understanding the referral process to maybe mental health providers. You may not have all of that in your clinic together if you don't have an integrated model. So are you familiar with all the resources that you have in your community? So there's a lot of training that goes with that, and understanding that. And that's right there where we see a lot of people just, there's a big dropout right there. Like it can be expensive to do the trainings. I know they've been improving a lot of the reimbursement for providers and even their teams being able to get the training to continue with expanding OTPs and MAT programs. Minimal counseling in order to get insurances to cover the appointments, and just getting them into counseling alone is difficult. And then you see the financial and reimbursement barriers that are obvious there for all of us, and working with Medicaid and the state and grants and all of that. That's no easy task getting on board with that. That's pretty much all we have right there for our slides today, other than on this next page there's a couple links to good websites, SAMHSA and oh yeah, thanks. SAMHSA, they just have a lot of MAT overview, a lot of things that I've been using that has good guides there. And then what was the other website? NIDA. Yeah. So NIDA, NIDA. That's another great website that has a lot of studies in there, and education for providers, patients, pharmacists, therapists, everybody. Those are great websites to use, and I consistently am going to those sites to look for better ways to improve our own program.
So we've had two additional participants join us. Perhaps they can introduce themselves. Nikki? Okay. Maybe not. Steve? Oh, we just signed off. Oh,
yeah.
It's cagey. This is.
Yes, stage fright.
Okay. The goal was not to drive people away, but actually just to engage them. Okay, maybe we could talk a little bit about the nuts and bolts of how things work at HOPES, at the VA. How do patients get engaged in this program? Do they show up for this specifically? Are they patients who are in for other reasons, who describe their opioid use and then get engaged into the program? How does that happen?
I was thinking while we were talking, I think it's important, because we're all talking about HOPES, because we all know what HOPES is, but I don't know that our audience necessarily knows about HOPES. And I think that's an important piece to understand, because as the kind of agency that we are, we're pretty well set up for a MAT program. That isn't necessarily the case for everybody who's participating. So I think that's important. HOPES,
are you going to, okay.
Yeah.
Okay.
Yeah.
Sorry.
Yeah. So we are a federally qualified health center. We provide integrated care to people. So we have primary medical care, we have specialty care, we have a lab in-house, we have a pharmacy in-house, we have x-ray in-house, we have case management, we have behavioral health. So we have a lot of services all in one place. As I'm sure everybody here really understands that that's the best, how we can get patients better care. And so in our program, our MAT program, we are a specialty program within our agency. We have a lot of different specialty clinics. MAT is just one of ours. Our team has not been together for very long. We previously had a different prescriber who left last spring. And so we've been kind of rebuilding our team since that time. But we do have a very multidisciplinary team, as you can tell. So we've got our prescribers. We have 2 prescribers. Carol is one of them. And then Dr. Altonson, who's not here today, but who will be here in our future clinics. But we have our MAs here. MAs are such an important part of the process. I don't want that to be skipped over because they're very important to us. You know, our nursing staff, our case management staff. We're really lucky to have the team that we have. And so our process looks different for different people coming in. So as Pete mentioned, we have a contract with Youth Offender Court. We also have sort of a cooperative agreement with another substance abuse program in town called the Ridge House. So we take a lot of their people. And then we also get just internal referrals from people who come to Hopes for their primary medical care who are struggling with opiates, who come into our program that way. And so it's a different process right now, kind of depending on where the patient or the client is referred from. We're still trying to kind of sort out the best way to do that. Because although we're here and we're doing this clinic with you guys, we really haven't been doing this that long, and we've learned by mistakes, and we've kind of learned what works and what doesn't work on the ground. And so we're still very much in that process. And so we're making it work. And so that's why I think, while we're sitting here as the experts, I think it's important for everybody to understand that we're learning too. And so I think us doing this clinic and hearing stories and reviewing cases with you guys is also going to help continue our learning as well. So I don't know if you, yeah. How about the VA? I don't know if you want to talk about that.
Again, Mark Broadhead, addiction psychiatrist, VA Medical Center. Our program, our buprenorphine program is perhaps a little artificially, is designed just for folks who self-identify as having a substance use disorder. In my mind and in the mind of those in the ADTP program, it's a little bit different treating somebody with chronic pain who happens to also have been on opiates for 10 years and has developed physiologic dependence. That's a different kettle of fish and requires a kind of a different treatment approach as somebody who's been shooting heroin since they were in the infantry and now they're 38 years old and clearly has a substance use disorder severe. So a lot of our patients come in through the alcohol and drug treatment program, ADTP, and at first they may come in because they want to get off opiates, or they want to stop the cocaine, but they don't want to stop the opiates, or they want to cut back on their drinking. So they can come into the program for a lot of different reasons, and at some point in time, they decide, well, okay, let's see about the opiates. Some come in right away saying they want to get off opiates, and then they're screened as to whether they are a good candidate for Suboxone or whether we need to refer them on to methadone, which we handle outside. We refer them out for methadone. Some VA programs have their own methadone clinics. Our VA system here does not. So we're dealing just with folks who have identified at some level as having an addiction, if you will. They may or may not have pain. Going through withdrawal, you're going to have pain. There's no way around it. It's just a matter of how much and how severe. So we may use a clonidine-based approach to try to detox them if they've never come off before. If they've documented that they've failed enough times with standard ways of trying to get off opiates, and they meet criteria for ongoing method or opiate stabilization. And then the real trick is after we get them on Suboxone, buprenorphine, which generally isn't much of a problem. It's then deciding right up front, what are we going to do now? Is this going to be a long-term maintenance case? Is this going to be a rapid stabilization and a rapid withdrawal, or a more prolonged withdrawal? The real art of the game here is deciding what are you going to do once you got them on the Suboxone. And kind of the real trick is, it's like picking your nose. You got to know where you're going to put it before you start. But recognizing that may change.
I never heard that either. So I'll never forget it.
You put it out there, but in your own mind, it's important to know. And that's a difficult thing because it can change from moment to moment. You think early on, this person may be a detox over a 6-month period of time, and after a while, it's like, no, they're going to be on it a while. So being able to, in our minds, decide where this person is and where we think they're going to go, recognizing that our patients will humble us just about every time. So we currently have about 40 people in our program. We see about 23 patients a week. Initially, up front, we do a lot more weekly prescribing. And if they're doing well and they're on a maintenance phase, then we'll go to longer intervals, 2 weeks, 4 weeks. The alcohol and drug treatment program staff are the ones who are going to be deciding, along with the patient, what level of treatment they're going to have, whether they're just going to do less intensive, once a week outpatient visits, or whether they're going to be involved with our intensive outpatient program, and what groups they're going to be involved in. So it's a lot more individualized in terms of the therapy they're going to be receiving.
How big a staff do you have for this program?
For the Suboxone itself, right now it's myself and a nurse.
Okay.
Now obviously there's a lot of ancillary staff. The entire ADTP program kind of wraps around us. So we're just a very small specialty clinic within that. We're going to be adding components in hopefully the coming months. We're going to be adding an educational piece because we're going to be training our psychiatric residents to be familiar and comfortable with Suboxone, and most importantly with dependent patients.
Mm-hmm. So at Hopes, how many patients have you got engaged at this point?
10.
Okay.
We have, for currently Suboxone, we have 40 patients. About 8 of those patients are on Vivitrol, and we have 1 on Zubsolv, right? So in total, we have about 50 current MAT patients in our clinic.
And our referral process is the same. We can fast track individuals in. If we get a call from Ridge House, if they have someone, for example, recently that they were concerned may relapse, they thought that she needed to be seen to have some medication to assist, so we can fast track those. Or if patients do come into primary care, they can be identified. Some people out on the street will talk to friends, and then they say they know that they can come to Hopes, and then there's a process to get an initial appointment. Primary care provider then makes that referral in. And then we have the drug court too, or the youth offenders court. So,
Dr. Whitehead, do you find that beneficial, having that other aspect, where you have already a team that's selecting the individuals and kind of preparing them, filtering, this is going to be more of this type of treatment, this person's here for this addiction. Is that nice when they finally reach you, that you've really got a patient that, you have a better idea of really what you're going to be doing with them. Sometimes we get them, we're treating them for opiate addiction, but we don't have anyone we don't have an intensive outpatient program with us that's maybe already kind of prepared them.
You're having to build a lifeboat around them,
right,
rather than having come in a lifeboat.
Right.
Yeah.
So sometimes we're treating them for opiate addiction, and they really have a meth addiction. where they would maybe need some extra care somewhere else, you know, before they actually got to us, or, you know, either way.
Well, and sometimes it's, you never know. It's not until I see about 4 or 5 urines that it's like, oh,
Really?
methamphetamine keeps coming up here. You didn't tell us about that. So it's always a surprise.
And there's that continuum of readiness as well. So you
It comes
do a
with
lot
it,
of
yeah.
that.
But it's nice having somebody who's, you know, some added information before they show up in your office.
Yeah.
That goes into trying to help decide, where do I expect this induction to go? Where do I expect this patient to sit? Am I going to do a rapid detox because they're going to prison? Or am I going to do a more gradual detox? Or am I going to just look at, let's stabilize them and just get the needle out of their arm at first and try to keep them from dying accidentally? And we'll begin to sort out what their social life is about and what are they going to need to be able to be successful in not just coming off the opiate, but staying off the opiate, which is always the tough part.
Is that something that they have? You know, when they get there?
Yeah. Dr. Altamimi, do you have patients who you're currently treating?
Well, yeah, we have, I have a few of my patients that they are on methadone, but they are going through MAT program in Carson City. And one of the challenging I face that patients who are on methadone, they come and they are demanding to have other medication like opioid or Ritalin or other kind of controlled substance. So,
And do you have, at your facility, do you have any support? Are you there on your own? Do you have a team?
Well, Nevada Health Centers is another clinic which is federally funded. We are 3 physicians and there are nurse practitioners, and we have a licensed social worker in behavioral medicine, but we do not have a lot of experience on opioid or addiction medicine in our clinic. We usually send them to psychiatry or psychology, or we send them to the some form of MAT program.
Okay, thank you. Dr. Van Gilder, what about, have you got any help, or are you kind of, you're it?
No, it's just me, unfortunately. We're hoping to get a little bit more help at some point, but yeah, it's been a definite learning process for sure. One question I was going to ask is if you could speak to your experiences with diversion of Suboxone. We've been having some issues with that out here, I'm sure everywhere. That, and then I'll pose other questions at another future date.
Great.
Yeah, and just just so you know, we will, that is one of our clinic topics later on. We're gonna have a whole clinic about diversion. So we'll talk lots about that. But yeah, I think that's also a major barrier for people to prescribe, is that concern, the liability concern related to diversion. What more specifically, what are you just
what do you feel like in your population? Is that a pretty high incidence that you have a worry for? Is there a certain subpopulation where you see that more?
Yeah, so a lot of our patients are young offenders because they come from youth offender court, and so we have a lot of diversion that happens in that group, but we also run a very tight ship, and so I should say we have a lot of attempted diversion, but we catch it pretty quickly, and because we're such a tight team and because we all know all the patients, it sort of limits the triangulating and the splitting. You know what I mean? Like, we communicate pretty well, and so when they're telling me one thing and telling Pete something else and telling Carol something else, and so we can kind of kind of keep it under control for the most part. I'm sure there are folks that are getting away with it. I don't think there's any way to control that completely. There's just not. But I think it's really important to recognize that, you know, folks who struggle with addiction are very sophisticated at manipulation. And that's not to say that that's a bad thing. It's just, that's how they have survived. It's a survival skill. And so it's really important that when you catch somebody engaging in those kinds of behaviors, that you're not shaming them, because that is not helpful. And so coming at it from the angle of, you know, I understand why, you know, this is where this is coming from. How can we fix it? You know, what can we do to make it better? And it's hard for you. It's extra hard for you because you're flying solo. And so, you know, that's a whole nother issue. Do you have providers? In, where are you?
Lovelock.
Lovelock. Do you have behavioral health providers that you can refer people to who are getting medications?
Yes, inpatient.
Just any kind of, you know, individual therapy or anything that's available?
Yeah. So we have general counseling out here through Lovelock Mental Health and through Atlas, but they're not as well set up for substance abuse. We do, however, have New Frontier through Fallon. That does have folks that come out here a certain number of days a week. It's a little bit limited. I think there may be only one now that's coming out here, and I just have one of my patients who is seeing that provider and is, I don't know, they're having a little bit of a conflict, but I'm going to need to kind of speak with him. But so we do have some resources, which is good.
Good. So for us, we have, it's different in the rurals. For us in our program, it's absolutely mandatory that anybody receiving medication-assisted treatment is in some kind of therapy. It's not a choice, because medication-assisted treatment on its own is not as effective, obviously, as, you know, medication-assisted treatment with the behavioral health component. And so it's different in the rurals, where if there are no providers to provide that, then the best care would be just medication-assisted treatment. At least you're getting them to some level of stability. But if you do have those resources available, you know, I would strongly encourage, you know, that to be that just has to be part of the program. That's the way we do it.
And we bring people in really quite frequently. So we have daily dosing, and if they have random pill counts. So if there's some discrepancy, then they come in more often. It's sort of a little bit punitive, but it's consequences, and that may not prevent all diversion, but if we know
it's not
exactly,
punitive. Let's not use that word.
It's clinically appropriate.
Right.
Yeah.
That's the consequence.
So it's a consequence of that failure, or if they don't have things in line with our expectations, then we just bring them a little bit more often.
Are you concerned about diversion as far as them taking the medication in a way that they're not supposed to, or are you concerned about them selling it, sharing it, or?
Yeah, so all of the above mostly, but I just, I had a patient on treatment who came in and told me that someone else in the community had solicited them for sale of their medicine. And so there's a whole other spectrum of how it came out that that person knew this person was taking Suboxone. And it's a lot more convoluted than that, but we have a pretty big heroin use problem out here in a certain part of the city, and I'm finding out lots of interesting information about how people are using Suboxone to bridge their heroin use when they don't have it, and this is all kind of new to me. So I am just trying to get some more information.
My take on all of this is for the diversion. You've got a bunch of folks who've been shooting heroin, and one of them comes in and gets some Suboxone. And the next thing you know, you hear you're right, they're using it to bridge. this is the start of a conversation, not the end of a conversation, because we know they're going to do that. I am much less worried about an accidental death due to sharing of Suboxone in that community amongst those folks, because these are seasoned pros if you're shooting heroin. And you're bringing a knife to a gunfight when you're talking about Suboxone overdoses in that population. I'm much more worried about them leaving their medications out for their kids to get a hold of, because that can kill them. So I expect a certain amount of leakage, if you will, out into that particular community. We're going to do things like do pill counts, which is nothing more than really an IQ test. When it comes right down to it, if we really want to get technical, you can do some of the things that the methadone clinics do, which is to mark the pills. There are little pens you can use that put an invisible mark on it. So you mark all their pills. And then when you call them in and their pill count's right, but only half of them have got the mark on them, hey, they're sharing around. So, if you want to drill down to that level of control, you can. What we do is we just put them on a tighter leash and simply say, well, you're coming in for weeklies. And the most they can get, they can give away or sell is 14 pills. So my mindset in that population who are using heroin is this is a harm reduction technique. Okay, if your buddy needs some Suboxone, we'll tell him to come on in. We'll get the needle out of his arm and get him on some Suboxone. And it's a public health issue rather than an individual treatment issue. Now, if it's clear they're not showing up to their outpatient treatments, their urine is still dirty for everything in the world, there's absolutely nothing wrong with firing them. And we've done that in our clinic a number of times. And of course, they try to hold us hostage by saying, well, I'll go out and use. And my response is, you already are. So at that point in time, it's kind of the provider's own personal limits and your comfort level. If you one other technique to kind of look at how much are they actually taking of their drug is to look at urine buprenorphine or buprenorphine levels. They're expensive, and we're the federal government, so we waste money all the time. I do them almost every time, but we're hoping to kind of get a picture of, can we use buprenorphine or buprenorphine levels to kind of correlate with how well the patient's doing.
Can you check like levels? So this is something else that just came up. One of my first patients who I saw was an established Suboxone patient, on it for years. Comes in, I do the usual everything, including buprenorphine, norbuprenorphine, and it came back as the first one I'd ever seen. Came back with positive for both, but I don't know like quantities of the numbers, so I'm like, okay, looks like he's using his medicine. Then I have another patient like 3 months down the road who I get her lab results back, and I'm like, whoa, that is a majorly high number compared to my other patients. So is there a titration level, or is it super individual and you don't know?
It's individualized. It can have things that can affect it are other drugs. If they're on other medications, it can affect the metabolization. When they took their medication in relation to when you took their urine can play a role in it as well. We are kind of playing around with the idea of peaks and troughs. If I've got some guy who's on 24 milligrams of buprenorphine, every receptor should be saturated at this point in time. But his levels are like 7 and 25. He's not taking it. But there's always that little nagging thing in the back of your mind. Is he special? Is he different? And so we brought him in, did a urine on him before he took it, made him take it in front of us, An hour and a half later, drew another one. At the end of the day, because he was in treatment all day long, drew another one. And indeed, he just wasn't taking it because he was nothing, real high, and then in the range I would expect at the end of the day. And we confronted him with that. And he quit the clinic that day. Okay. We've had other guys who we're still negotiating with, but I mean, it's time intensive, but you can kind of begin sorting some of this stuff out. I suspect what we're going to end up doing is if they're doing well, we're not going to check it. It's only when they're not doing well that we're going to, just as with methadone clinics, that's when you do peaks and troughs and that type of thing. That's something you can do if you have the time.
Right.
Yes.
It's a vulnerable population, and you know, they're a lot of this population. They're very poor and they need money. And you know, if you find somebody who might be suspecting that they're selling some, I mean, you talk to them maybe about other resources. Like, hey, have you talked to welfare? Right? Do you have food stamps? What is it that you need? I mean, do you have family that you're trying to support? Sometimes approaching it from that aspect and trying to help them, you know, meet their basic needs, then they're not so much worried about like that extra money. I mean, those are rare cases. You know, usually the guys that are selling it are just, I mean, I don't know. Maybe they really need the money, but it's money to buy things that probably aren't for basic.
It's just a business then.
Yeah, it's business. But yeah, I mean, you can approach it from that, and it's an educational piece.
Yeah, scratch the surface of most addicts, and you're going to find a highly codependent individual. And so they've got a friend or their child, and we've got a lot of 65-year-olds in our clinic. You know, it tends to run in the family, so their 30-year-old son is also heroin dependent, and so they're trying to help them out with some of their Suboxone as well. So, you know, sometimes just having a conversation with them about where's it going, without the threat of being thrown out of the clinic, sometimes they'll come clean.
Two other quick questions. Number one, so we have a fair amount of Medicaid patients here. Typically, Medicaid will only approve or pay for a 30-day supply of medicine. So I was having some difficulty initially doing a week's prescription because then Medicaid wouldn't pay for more. But I've found out that I can maybe do that. I just have to do a prior auth every single time I do that, which is another timepiece of frustration. But at least I could do it. I just found that out. And then the other question is, do you ever treat spouses with the same medicine?
Yes, and yes. We do prior auths, and that has been something that we've had to learn a lot about. Because we're doing it more frequently, we find that you know, some Medicaid Amerigroup is a little bit better about covering the initial costs for like a month or something, but then you find out that it suddenly is cut off.
They don't have that in the rules, right? You guys just have
you have fee for service probably, yeah.
I think so.
Yeah, so yeah, they'll do like an initial like 30-day, and generally what we'll do is like the day before that maybe they're due for another dose, we'll turn in another script, and they will kick back a prior authorization. Now, sometimes that goes through the pharmacy. Sometimes you just have to call Medicaid and you have to find out where they're kicking back those prior auths. So they send it to your office, or is it going to a pharmacy? Jennifer actually does a lot of those for us. I mean, I've had to learn how to do them, but Jennifer can get them done really quickly.
Well, and I just want to say real quick, Jen, this is the nice thing about having a pharmacy at Hope's, is this stuff is facilitated. Because the problem is when you're dealing with all these different individuals and people who are too busy and don't have time, not enough help, it just takes a second. You know, we can talk on the phone quickly, we get them what they need, and then they can go. And whether it's changing from tabs to film, whatever, it's quick. And I don't know, you know, outside of our environment, how that's, you know, when you're dealing with all these different pharmacies, how you make that better. Because Pete can just run downstairs and we can take care of an issue and it's good. And that's just a wonderful thing about where we are.
Yeah.
One of the, I'm going to interrupt this. One of the things about this program, I think, is the opportunity to find out where the impediments to care are. And I think because this is, the state has an interest in this, we may be able to get our state Medicaid folks engaged and say, hey, you know what, we've identified this set of problems. These are impediments to getting our folks treated properly, and maybe we have some opportunity to leverage that. So I think finding out about these issues is really important, and we need to really track them carefully and make sure that we are engaging when we can.
The next question, I have no idea because I've been sucked into the black box of the VA for a number of years, and we have our own pharmacy, but when I was with the university, if you've got a good relationship with the pharmacy that you're working with, and if they're concerned about this individual, sometimes they'll only give partial fills. And if you can get them to kind of go along with it and say, okay, we got a 30-day script, but they're only going to fill weekly, so they'll just give you partial fills throughout the week, throughout the month. Sometimes that can be a way around it. I think the pharmacy's got to be willing to eat the cost of the dispensing, but if the pharmacy has a heart, sometimes they'll work with you. I don't know, is that
Make
possible?
friends.
Yeah.
The pharmacy with a heart.
We have a very small pharmacy who's had a little bit of staff turnover, and we have some of the other challenges on top of just this. So depending on the month, yes, we can do that.
Okay.
We interrupted you.
Oh,
so-
no worries. I was just gonna mention, how are you, with your prior authorizations, are you only getting it approved for 30 days at a time? Because what we do, or what I do, is because a lot of patients are starting on a certain dose, and sometimes that dose doesn't work for them. So they go to, say, they're on 4-1 milligram films of Suboxone, they go from 1 a day to 2 a day. So to get that prior authorization to last longer, we get it approved for up to 60 days at a time. So we have that room to titrate up, and it gives us a longer life on that prior authorization before we have to do another one when they go up on the dose number.
So I don't have a way, as far as I know, because I'm doing all of my own. So but when it comes back approved, it usually does approved for 1 year.
Right.
When I get my approvals. But then if I have to change doses, then yes, we go through that again. It's actually not too hard now that I've got it down. However, Medicaid also requires me to put in the treatment facilities ID number, which I've had to coordinate with New Frontier. Unfortunately, they gave me their ID number. I don't have a guarantee that my patients are going to see them. I give them the referral. They go, we talk about it the next time. So there's a lot of trust in that. And it's also a little bit tough, but definitely a work in progress.
Yeah.
Any tips for the prior auth, send them my way.
Well, that would be my one tip is if you're, instead of doing the 30 days at a time, make the prior auth for like 60 days at a time. And it'll be good for a year unless you have to go up that dose and then you do it again. But that'd be my tip.
If you suspect that somebody, you might be moving them up in dose. If you suspect that they're going to end at like an 8 milligram dose, you can kind of jump the gun a little bit early. And so when you're maybe moving from 2 to 4 milligrams, you might go ahead and give them a script for an 8 milligram film, but they're only going to do half of that to make 4. And so you are eliminating that process of having to get another prior auth for a new strength of film. And so those are things that we've learned. So, or what we do is we do 2 4 milligram films to make 8. And generally when we're going from 1 4 milligram film to 2, they won't require a new prior auth. But if we're going to go to 3 4 milligram films, like a day they will want another one. And so the most common ones that we use are just 4 and 8, because from 4 and 8, you can either get 2 milligrams, you can get 6 milligrams, you can get 8 milligrams. And then we go to the 8 milligram films where you can get 12 and 16. So we never prescribe 12 milligram films. I mean, it just don't work for us. And the prior auths are a hassle. So sometimes you learn the pattern that they will approve and going up in doses, and you can anticipate that.
Yeah.
And generally, we will tell our patients, plan on having money for maybe like 3 days worth of having to cash pay while you are working on that prior authorization to get some of those approved. And if they don't have much cash, well, sometimes you can do, you can ask the pharmacy to dispense tablets, the Suboxone tablets, where it's still the same, medications, buprenorphine with naloxone, but the tablets are only like $250.
Cheaper. And we should mention, because of our status, we get access to great pricing. So, the whole idea with that is it's really access dollars, really, that you can play with the savings so people can get what they need. Because obviously, by not coming to us, the prices are outrageous. So, and that's
Now, back to the whole idea of you can only get them a month's supply, but you really want to dispense weekly. Some of the things we've done is, especially with our younger population where there's a responsible second party involved, a mom, a dad, somebody who lives somewhere else, we'll make a contract with that patient that says, no, you're going to go to the pharmacy with your mom, and your mom is going to control that medication, and she is going to dispense to you a 7-day supply of that medication. Place I worked before, we could lock it up in a vault. So they would go, they would get their medications, they would come, they would count it in front of us. We would all agree that's the amount of medication they had, and then they would come in once a week and get medication out of their stash. So anything you can do to kind of limit them is fair game, depending upon their social resources. So you can get creative. There's nothing that keeps you from doing that, in terms of requirements or regulations.
And then the other question. We do. We have in our program, right now we have 3 couples. We have 3 couples in our program. And just a couple of weeks ago, we made a new rule.
Absolute rule.
Absolute rule. Because the couples want to come in together, they want to sit in on each other's appointments. It was creating a lot of problems. And so we are not allowing them to do that anymore. That they have to come alone for their appointments and answer their own questions. But I think, I'm curious why you asked. What, you have something?
Well, one of the issues we've had recently was involving a spouse, and the other spouse has been compliant as far as I know, but there's been a lot of things I can't talk about here, but so one spouse is no longer going to be able to get treatment here. The other spouse is due to come in today, actually, and I need to decide if I'm going to continue that or not. I probably will not, honestly, given the situation, but I will give him a month and refer, because he was already getting treatment somewhere else before I took it over as a convenience thing. But I just don't think it's probably appropriate anymore.
Well, I would say go with your gut.
Yeah. The likelihood of relapse is pretty high if the spouse is using.
Mm-hmm.
We had one couple that, we really had to be stern about the dosing, because during the visits, it was interesting that we were finding the boyfriend was talking more about his girlfriend's dose than she was. And so we were like, who's really getting the medication here? How much are they really taking? And so, yeah, they still may be doing that, but we were seeing an obvious, interference with whatever dose that patient really wanted to take. And you could see them like, no, I think she needs to have more. And she's going, no, I want to go down in dose. So yeah, I mean, they don't really reveal as much as they should if they're not alone. And we've just decided we're not even going to talk about dosing to each other. We told them that we'll share appointment times, and that's pretty much it. If one is calling about like when is the next one's appointment because they're not available, that's maybe about all that we'll share. But we're not going to be talking about medication dosing or anything. That's something that they'll have to decide.
So it sounds like if you've seen one case, you've seen one case.
Mm-hmm.
Yeah. And it sounds like each one of these scenarios is going to be fairly unique in this. But, and it sounds to me like having these discussions can be incredibly valuable because they're so complex and challenging and high stakes. Right? So it's great.
Thank you.
So we reconvene in 2 weeks?
We reconvene in 2 weeks.
Okay.
Any other questions?
Yeah, Ryan, any questions from your group?
We don't have any questions at this time. We were just going to share a little bit about our network.
That'd be great.
Yeah. Okay, thank you. So we are based here in Northern Arizona. Like Brian said, we're a managed care company for our Medicaid clients in Northern Arizona. We have a large geographic area that extends from the California state line to the New Mexico state line to the Utah and Nevada state lines, and then almost down to Phoenix. So much of it is rural, if not frontier. One large problem of ours is having the provider base to serve our clients in all ways, but in particular in relation to opioid treatment. We have 12 health homes. We use the health home model here. And one of those health homes is an OTP, an opioid treatment provider, and it's based in 3 different locations. So our OTP does prescribe, obviously, methadone as well as Suboxone. But at our other health homes, we do have a handful of providers who will provide Suboxone, but we don't see a lot of those outside of the OTP.
So the beautiful thing about ECHO is that because we are completely HIPAA compliant, all of our case discussions are de-identified, right? We never reveal protected health information. And because we're not providing direct services, we have no concerns about state borders. And we would be delighted to have your providers participate. Obviously, your state has a grant to provide these services, and our state has a grant to provide these services, but until we reach our max in terms of servicing our state, we're perfectly happy to engage with you guys. If we reached a point where we had so many Nevada providers on board, we might give them priority over yours, but if your providers wanted to participate with us, we are certainly happy to have them.
Thank you.
And then if you want to send some Arizona dollars our way, that would be great too. We'll have another discussion about that perhaps. But that's great, and it sounds like, again, I think the term that I use is that there are sleeper cells out there. There are folks who are certified who are not engaged. And the goal for us is to get as many of those certified providers engaged in prescribing because the needs are so enormous. And we obviously recognize that there are tremendous obstacles, as we've talked about here, but we think that this mechanism might help us get where we need to go. I'd like to float an issue because I'm the governor for the Nevada chapter of the American College of Physicians, and our Board of Governors convenes next week, and we're considering resolutions, and one of the resolutions that was put forward was to eliminate the 8-hour trainings for certification to prescribe Suboxone. And to my surprise, there was a lot of debate about the importance of that. My take, and I'm putting that just out there to see what you think, is that the 8-hour certification is not the impediment to actually MAT.
Yeah.
You know, to me, that's that's a distraction, and probably it's more than is truly necessary, but I don't see that as the problem, and I was wondering if you all felt similarly, because that's the least of it, as best I can tell. Not that I don't do it, so I can't really speak to it, but it just seems to me that plenty of people are certified. It's just not doing it.
Well, so to two things there. Yes, I think the sleepers out there are definitely people that we want to target. I know reimbursement has been a concern for people getting the 8-hour certification training. And so part of what we are working with one of our regional medical centers in Yavapai County, which is in Prescott Valley area, if you're familiar with Arizona at all. We're working with them, and we actually found that the doctors were very willing to even work those, to do that time for kind of reduced fee with some amount of reimbursement that the hospital itself won't take too big of a hit. So I'm personally not a huge financial compensation. The entirety of the hospital ED is very willing to consider becoming certified. So some manner of compensation may, and we'll let you know in the next couple of months, help us to jump that hurdle to basically get an entire ED trained.
I'd be interested.
And the training is quite good.
The training is
It
good.
is quite good.
Yeah.
I did the 8 hours 7 years ago, and just for edification, and then PAs and nurse practitioners, they've increased that to 24 hours. So that is a little, it takes 24 hours is a little more, but that 8-hour course goes very quickly, and they have a nice format. It's engaging. They have good cases that they present that I don't think that's really a problem, and it's not that expensive.
Thank you. So, we're rolling. It's great.
Yeah, thank you for having us.
Thanks for joining.
Yeah, of course, anytime.
Nice to meet all of you.
Thank you very much. Sorry I have to run.
Okay.
Thanks. Hopefully we'll see you again.
Well, congratulations.